So thank you, Dr. Siegfried, for being here again, and we'll turn it over to you.
Thank you, Ann. Glad to be here. For those of you who know me, I'm quite informal. So if there are questions, raise your hand or shout out and we'll answer. There is a chat box that I'll have to bring up occasionally for the studio audience to have them weigh in. Thank you. I may be the most educated person on CHF in this room, but as my wife frequently points out, I'm not always right. I just sound like I am. So there are differences of opinion about some of these things. And certainly anybody chime in at any time. And as it says in the book of Acts, believe, but trust and search yourself. Learn for yourself about some of these things that I bring up, especially things that may seem controversial, and pull me aside and stop me. We'll talk some more. In terms of
yeah.
In terms of disclosures, I have no financial disclosures. And we'll get started. Everybody that comes on into the room, please sign in. I think there are some raffles, and if your name's not on the list, you're not eligible. I'd like to break this talk up into 4 parts. First, I want to define congestive heart failure. It's not as easy as you think. Then I want to talk about the diagnosis, and I think there's going to be some surprises here for you folks. And then we'll switch over to outcomes and prognosis and try to highlight differences between the diastolic and the systolic aspects of heart failure. And then finally, we'll get to the meat of the matter, which is treatment of congestive heart failure. I intend this talk to be very practical. There is some scientific information presented, but I want you guys to understand why we do what we do, and then let's try to do it. So looking through the literature, there have been various definitions of congestive heart failure, and I won't read every word on each of these slides. And I believe a copy is available. They're recording this, and you can go back and refer to it. But essentially, we have a problem with blood flow. And the gold standard for diagnosing heart failure is that the pressures in the heart are elevated, and these are best estimated invasively, although we very frequently do not put swan catheters in our patients because we end up with more complications than value. So there are some things we do to try to guess what the pressures are within the heart, mostly ultrasound, and then some lab testing to try to guess what those pressures are. But the gold standard is really to measure the pressures in the heart and see if the heart is filling properly, and is it filling at normal or elevated pressures. Now, the official definition of congestive heart failure from the guidelines: signs and symptoms that result from any structural or functional impairment of ventricular filling or ejection of blood. There are 2 points that I want to make in this definition that are glossed over, and words are important. First is congestive heart failure doesn't always involve a problem with the heart. For instance, someone could come to the hospital with extreme blood pressure, 250 systolic. The heart can't push against that. The heart ends up in failure because we're asking it to do an impossible task. So it's not always a heart problem, although it always results in the heart having problems. Second, and this confuses a lot of patients, and I see this in the office a lot, congestive heart failure is not a disease. It's a set of circumstances. See the first 3 words there, signs and symptoms. So if I fracture my leg, you do an x-ray, you see a broken bone. That's a condition. If you have diabetes, you know that you don't handle sugar properly. But not all diabetics have high sugar all of the time. So congestive heart failure is a situation where your heart isn't in balance with the circumstances it's living in. And we can get people in balance, and at that point, they no longer have congestive heart failure, although they have a tendency toward it if they get back out of balance. So the same with diabetics, we can get their sugar right and they still have diabetes, the disease, but they may not have high sugar at that time. So cardiomyopathy is a disease and diastolic dysfunction is another condition people can have. Congestive heart failure is when those things get out of sorts. We classify and we also stage congestive heart failure so that we're saying the same things to one another. And you'll see these in notes. And when you see this, it's like a description. I can describe an EKG as having bigeminy, and it's a shorthand for me, and it means every other beat is a skipped beat. Or I can say New York Heart Association class and then list numbers, and people can get an immediate idea of what's going on. It's hard to remember some of these things, but when you have a list like this, the best thing to do is to know the extremes, and then the middle part of the list becomes very easy to figure out. So New York Heart Association class 1 are people that have no symptoms under any circumstance. You can't tell they have heart failure by looking at them in any way. And class 4 are people that no matter what you do, they're in heart failure. And then in the middle, we have people that have minimal symptoms and people that have marked symptoms. So if you remember the extremes, the middle part becomes a little bit easier for people to remember and to figure out. And not only do we have classification, but we have stages. And again, if you understand what's going on in each one of these definitions, then you don't have to memorize what the definition is. Stage A are people that have the potential to develop congestive heart failure. They've never been admitted for it. They don't have any symptoms, but they might have a condition like chronically untreated blood pressure, and someday that's going to lead to heart failure. Stage B are the people that are pre-heart failure. C are the people we see in the hospital all the time. They have heart failure. And D are screwed. These people, there's nothing we can do to help these people within our facility right now, although in the future, we hope to be adding some advanced heart failure therapies. But those people, it's refractory. No matter what we do, no matter how much medicine we give, we can't get them any better. These are the people we send on to Emory or St. Joe's, and we're thinking they need an LVAD, or they need mechanical support, or they need a transplant, or they need palliative care. Another point about heart failure is it is a progressive disease. It gets worse. It doesn't get better. Think of it like arthritis. There are things you can do that encourage arthritis to get worse. There are things you can do to slow it down, but whatever your joints look like at age 9, they don't look like that at age 90. So heart failure tends to progress. Things that we can do in the early stages to identify people in stage A and B and try to prevent them from getting to stage C makes the sunset longer till they end up in stage D. So this is all about delay till the latter stages of life. So we want to try to identify these people and try to keep them out of stage D. Now, this is a little bit boring, this part of the talk. It's kind of the mechanics behind things, but it's extremely important when you think about what's going on with each of these diseases, what's going on with each of these therapies. And what we're going to talk about with remodeling is true in any other part of medicine. So the body, I'm sorry?
Yeah.
Oh, Annette, mute your phone. Here. Oh,
That's okay.
she got it.
The body has a change that goes on when it's exposed to a condition, whether it's arthritis because our joint's getting worn and the joint tries to repair itself and the repair process isn't quite up to standard. But remodeling is what happens in the body when it's exposed to some sort of pathology. Initially, the changes in remodeling are favorable. They help with the situation, and they're usually brought by mechanical forces or hormones. And we'll see some of the ones specific to heart failure. And these changes we can sometimes see at the physical level on ultrasound or on X-ray. We can sometimes see them at the biochemical level with some labs that we're going to draw. And what they do initially is they alter how the heart muscles react. and help the heart, but eventually these changes lead to problems down the road. So we want to try to prevent the insult. And if we prevent the insult, we prevent the remodeling, which at first is good and later on isn't so good. And if we can interrupt this process early on, it's to everybody's benefit. Now, no matter the disease, there are changes and they follow this same pathway. So there's an initial insult. The body tries to compensate various ways, depending on which organ we're talking about. This adaptive response is initially good, but then it becomes sort of maladaptive. And if we interrupt at this point, we can usually push things back the way they were. However, if we get to the maladaptive stage, then we start to get irreversible changes in the heart. And these irreversible changes lead to further reductions in the LV function. So as that ventricle starts to stretch out because it can't handle the load, it becomes weak and puny and can't do its job. And then when it becomes weak and puny, the tissue changes so that we get more fibrous tissue to hold back the ventricle from, say, rupturing. And then that fibrous tissue leads to arrhythmias. And once that fibrous tissue is established, the heart can't grow new cells, we're in trouble. And remodeling can come two ways. There's eccentric and concentric, depending on whether volume is involved as what's assaulting the heart. And when there's volume involved, it's usually an issue where the heart has to push more and more and it stretches out, and that's eccentric remodeling. We see that with kidney failure, we see that with valvular heart disease, and then pressure can be involved, and we see that with concentric remodeling, where the heart's working under higher and higher pressures, so it gets bigger and thicker and more massive as a muscle. And a stronger muscle pumps better, but a stronger muscle needs more oxygen, so then it runs out of oxygen and it starts to die off, not because it's got blocked arteries, but because the massive muscle can't sustain itself. So if we can interrupt these processes, we can prevent these changes, and then we can prevent some of the end stage things that happen. So this is kind of boring and more sciencey, but it's going to have implications when you think about what's going on with your patient and how to make these changes. And we talked about the three patterns, and you can have concentric, eccentric, or a combination of both, but I won't belabor what causes each. So how do we diagnose congestive heart failure? Well, we can use symptoms to try to make the diagnosis. Symptoms are nice because you can ask the patient, you can get feedback. Symptoms are troubling because they're very subjective. Some of our patients are kind of stoic and they're very short of breath, but they won't admit it. Other of our patients, if they have a paper cut, we think that their arm has been cut off. So there are some issues there. Sometimes these symptoms develop so insidiously that they're not obvious to the patient. But the major problem with symptoms is not everybody gets the same symptoms each time. So dyspnea, orthopnea, edema, pain in the abdomen from distension of the belly from fluid collecting there, fatigue and weakness. Each one of these symptoms has a concept behind it called sensitivity. That means it's present when the disease is present. So you want a high sensitive symptom to make sure that you have that disease, but they also have specificity. Dyspnea could be present for heart failure, but it could be present for pneumonia. It could be present for anemia. It could be present because someone has asthma and they sucked in the wrong thing in their lung. So orthopnea is a little bit more specific because it involves dyspnea in a certain position. Oh, sorry. You said right. So dyspnea is 89% sensitive for somebody. If they come into the ER and they say they're short of breath, there's a high likelihood that they could have congestive heart failure, but it's not very specific. Many people come in with dyspnea, so it's essentially a coin flip at that point to say, oh, they're short of breath, it's heart failure. And orthopnea is much more telling because with orthopnea, we're not as sensitive. And orthopnea means when I lay down, I get breathless. When I sit up, I don't. So orthopnea is a little bit more specific to heart failure. And these others all have sensitivities and specificities. Unfortunately, none of them are 99% accurate. None of them are present only with heart failure and absent when you don't have it, and not present with some other condition. So I can't say that if the tip of my right index finger hurts, I have heart failure, but if it doesn't hurt, I don't. We don't own a symptom like that we can use all the time, every time. We can also try to diagnose by physical exam. So if I feel the heart beating and the tip of the heart, and anybody can do this in the room, you put your finger on your chest and try to find where the tip of your heart is. If it's displaced way off to the side, I probably have a big heart and it's probably weak. That's why it's big. But again, it's not necessarily specific. I could have a collapsed lung that could be sucking the heart over that way. I could have fluid on one side of the chest shoving the heart over that way. So I can't say that that's always true. But distension of the neck veins, swelling in the ankles, bloating of the abdomen. An S3 gallop is fairly sensitive and specific, but it's hard for an examiner to hear. And then things like crackles and rails. Again, all of these things can be present and often are present on the diagnosis of congestive heart failure, but none of them are specific for it. I can have crackles and rails in pulmonary hypertension. I can have that also in pneumonia. So we can't use any one thing to make the diagnosis. Generally, the EKG is not very helpful for congestive heart failure. It's great for an acute MI, but not very good for congestive heart failure. There are some shades of meaning that might give us some clues. Troponin is elevated in most people with congestive failure because myocytes are dying off little bits here and there from the problem the heart is struggling with, whether it's extremely high blood pressure or a leaky valve causing the heart to stretch out and cells to die off. But again, it's not very useful. Hyponatremia, when it's present, tells us that someone's going to do worse, but hyponatremia by itself doesn't diagnose heart failure. So what we as cardiologists normally see in the ER is somebody walks in with dyspnea or into a clinic, and then the next step is they check the BNP. And at this point, the conclusion is they've got dyspnea, the BNP is elevated, it must be heart failure. And while that is possibly true, it's about 50% accurate. So if you follow this particular paradigm, or even worse, if you follow the patient came into the ER, fell down the steps and broke their hip, let's check a BNP, then they're going to say, well, maybe they have heart failure. It's unfortunately not specific. And I want to give a few words about BNP, which is a lab test we do because it's something that we can get easily in the ER to try to help us make a determination. So let's talk about BNP. And when I say BNP, there really are two lab tests. There's BNP and there's NT-proBNP. And they're both lab tests. We use the NT-proBNP, which is slightly better here than the typical BNP test. But it's a protein that gets synthesized in the heart under response for the ventricle being stretched out. So remember, our definition is that heart under high pressure, or putting a swan in, we find pressures are elevated. So this would be synthesized when the heart is under high pressure. It's not stored, so it's synthesized. So that means there's a lag between when your symptoms start and when the BNP goes up. If you have shortness of breath and show up within 5 minutes to the ER, BNP may not be elevated. Also, the variability in production of BNP is kind of astronomical. If Katie gets heart failure, she may have a BNP of 100 and may get a BNP of 500, and neither might be worse or better than the other. It's just how good are we at making this? So we can't look at the absolute number and say, this person's in worse heart failure than that person. We can try to look at a person's individual BNP and say, well, they were here 3 weeks ago with shortness of breath and it was 2,000. They're here short of breath now and it's 1,000. It's probably not worse than it was before. Maybe something else is making them short of breath. But the variability between patient A and patient B makes it difficult to make a cutoff value that's accurate. Why does the body make BNP? We think of it as this bad thing. It's actually, remember our remodeling model, it's actually a compensatory mechanism. The ventricle's getting stretched, the ventricle's trying to fix that. So BNP is a protein that acts like a diuretic. It's like Lasix that the body makes, and it'll help the body lose water and sodium at the same time. It'll dilate arteries to try to lower those filling pressures. It'll turn off renin and angiotensin. So it's kind of like an ACE inhibitor. The endothelium makes a bunch of substances that are very good for us, but it makes some that are kind of bad for us. Endothelin is one of them. So BNP's job by the body is to try to make the body get out of heart failure if it's in heart failure, or if the pressures and volumes are high in the heart. And we talked about the two assays. It starts out as just a pre-pro peptide. It's cleaved into a pro peptide, and then there are two products. BNP is the active one. NT-proBNP is the piece that's not used, and we can assay both. Our institution generally tends to assay the NT-proBNP. It's a little bit better of an assay, by the way. So what triggers BNP to be elevated? Well, if you're in heart failure, it does. If you have valve disease, it does. If you have an MI or LVH, it does. If you have trauma to the heart, recent open heart surgery or a contusion or a cardioversion. If you have AFib, if you have pericardial disease. So if we want to try to say dyspnea, elevated BNP, congestive heart failure, we already have a problem, because a lot of our patients have these other diseases and may not be in heart failure at all. Now, if that were the end of it, we'd be okay. All of these other things raise BNP. So if you have pneumonia, you can have BNP. If you have sleep apnea, you can have it. If you're a lady, you'll have more than a man. If you're old, your BNP levels go up. If you have sepsis or cirrhosis or high blood pressure, and even some of our medicines raise BNP. So we can't look at just someone that says, my BNP is elevated, I'm in heart failure, because there's too many other diseases that can mimic this condition and mimic the symptoms at the same time. So it's not quite as simple as we'd like it to be. For example, here is a study from the literature of people that are permanently in AFib on the left half of the panel, and people that never have been in AFib on the right half of the panel. And we break both halves into those that have a definite diagnosis of heart failure and those that don't. Well, the first thing to look at is there's so much overlap between these two groups that if we just try to use BNP to say heart failure, no heart failure, we're going to be wrong as often as we're right. And these are people in the far left box that had heart failure. And yes, they do have a higher BNP level, 500. And in the second to left box, they didn't have any heart failure, but some of them had BNPs above 500. The average was 100. So there is a difference there in terms of the averages, but the overlap is extreme. And then people without AFib, look at the spread of those BNP numbers. And if we don't just consider AFib, but if we also consider other things like people with valve disease, this is a study on aortic stenosis, and the control group's BNP level is 140, which, by the way, exceeds our hospital cutoff for congestive heart failure. And then if you have mild, moderate, or severe stenosis, that's what those next three bars represent, or you've had your valve replaced, the BNP levels are still high in all of these people, and none of them had any signs of congestive heart failure. But what's happened is the valve was narrowed, and even the replacement valve is narrowed, and it causes a little bit of back pressure in the heart. And that back pressure is read by the heart as, hey, I need to get some of this liquid out. Let me make my own natural defense against this BNP, so those levels are elevated. So how many of our patients come into the hospital with such a pristine past history that they don't have blood pressure or some degree of valve disease or any arrhythmias ever or high blood pressure? So we, using BNP as our cut point isn't necessarily a great idea to decide yes, heart failure or no heart failure. So I have shirts available in the lobby for anybody that likes BNP. And I'm not against you checking it, but when you get a result back, we have to really investigate and think about that result on the basis of the patient themselves. So here's the conclusions we can make on the BNP level. If the value is negative, you probably don't have decompensated heart failure. That's probably the strongest conclusion for BNP. It's a great test to exclude heart failure in your patient. It's not a great test to include heart failure. Now, there are a couple problems even with this point. Obese people have low BNPs. And if you come to the hospital too quick after your dyspnea starts, you haven't had time to rev up production, so you have a low number. So negative BNP is your friend. Positive BNP, unfortunately, says, well, maybe you have heart failure, but there's about 20 other things you could have as well. So elevated BNP, maybe it's heart failure. Negative BNP or a low value, now we don't have anything going on. So what do I recommend when somebody calls me and says, I think I have a patient with heart failure? I'm sorry to say it's very low tech, but the first thing I recommend is that people get a careful history. It's boring, it's not very sexy, but you can learn a lot when you talk to the patient. And they know what's going on, and they know better what's going on than their family does, as long as you can get a good history from them. Sometimes it's a little tedious. And then the next step is always a physical exam, looking for those signs we talked about to see if they might be volume overloaded. So I'm interested mostly in the weight, looking at the neck veins, looking at the, or listening to the lungs and the heart, and looking for peripheral edema. And then there are some labs that are a little bit helpful. Certainly, I want to know what their blood counts are, what their kidney function is like, and do they have hyperthyroidism, which often can mimic some of the symptoms of congestive heart failure. I want to look at an X-ray because I'll see a lot of clues on the X-ray that might give me some insight as to whether this is acute or chronic or whether it even is heart failure. But an X-ray is not perfect. CAT scan's even better, but I don't want to order a CAT scan on everybody that has it. I'm looking at the cardiac size, the size of the heart. Remember that remodeling again. If somebody has had congestive heart failure repeatedly, their heart's going to be big. Their atria are going to be big. The atria don't do much except lay there. So when they're deformed, there must be a problem with the valve below that atrium or the chamber below that valve. So it gives me some clues when I see large atria that maybe this has been going on a minute or a long time. Also, EKG. It's not terribly helpful, but it's low cost and it does give some clues, particularly if we see LVH. If someone has known heart failure and their QRS is wide, the wider the QRS, the sooner they're going to be shopping for a coffin. And certainly we want to be watching for any sort of arrhythmias. Let me check and see if anybody online has any questions so far. Nope. Do I click it again to make it go away?
Mine's the little chat box.
What tends to be very helpful, but you can't get it at the bedside, it takes some time, is ultrasound. And then cath is used to exclude CAD and if needed to measure pressures. So cath is not used very often in congestive heart failure. Most of these other things will tell us what's going on. So if somebody is new heart failure, if somebody is young heart failure, sometimes we'll go to cath rather than stress testing because we don't want to miss somebody with multi-vessel disease that might have some real problems. And if we fix things like blocked arteries, we can make the trajectory of this disease change quite a bit for people. So back to our definition, whenever the amount of blood coming into the heart exceeds the amount going out, we've got problems with congestive heart failure. And there are a number of non-cardiac things that can do that. Thank you, Anne. We've already talked about high blood pressure, but if the patient's just drinking too much, a couple weeks ago, we admitted a patient here to Duluth, and he doesn't have much in his life that he looks forward to, but boy, he likes his pickles. And he was eating 2 jars of pickles a week. And there's a little bit of salt in that. He didn't see anything wrong with it. He wasn't drinking a lot of fluid, but 2 jars of pickles was putting him into heart failure. And certainly if they're in the OR and they get hypotensive, that they're given too much, hypotensive, and they're given too much volume, we can put people into heart failure. Sometimes that happens during delivery of pregnancy, sometimes in the OR. If they're not getting rid of the liquid that they're taking in, if they take in normal amounts, but they don't get rid of it. And none of these are necessarily problems with the heart, they're problems with the patient. Now, if the blood pressure is very high, that leads to problems with the heart. There are a number of cardiac issues, though, and this is the direction we're moving in this talk now. We're moving away from the non-cardiac entities and closer to the cardiac entities. So if the valves aren't working right, the pump function can be great, but we're not moving blood forward efficiently and it piles up upstream of the heart. Or if there's something impeding filling, like fluid around the heart, tamponade. If the ejection fraction is poor, and this is the one we see all of the time and we deal with all of the time, or if we have a stiff ventricle. These last two can be thought of as systolic heart failure or diastolic heart failure. And with systolic heart failure, we subdivide it into what we call HFrEF, heart failure with reduced EF, less than 40, heart failure with moderately reduced EF, HFMREF, which is 40 to 50, and then HFpEF, heart failure with preserved EF, and that's greater than 50, and that's the stiff ventricle. So you may see all of those terms bandied about. Yes, ma'am.
At what point do we hold for therapy on kind of conditions? Because a lot of times we see like the ejection fraction like really low or blockages and such. Where do we hold for therapy?
You mean physical therapy?
Yeah, just do therapy.
Well, remember from the beginning of our talk, the definition is symptoms and signs. So if somebody can't participate in therapy, we don't want them to participate. If they have tissue that might be in jeopardy, let's pretend there's a 90% blockage that we want to fix, we would want to stay away from stressing that heart and provoking a heart attack. But if they just have a weak heart and there's no tissue in jeopardy, I want them to exercise. I want to try to improve the efficiency of the rest of their body. Most of our exercise that we do doesn't improve the heart's efficiency, but improves the container that holds the heart. And if that container is more efficient, then that heart can do better. Or a better way to state it would be, I'll never move a dump truck with a motorcycle engine. It won't happen. But if I take the bed off that dump truck and pull the hood and the fenders, the engine has a bit of a chance. So if you can get people to exercise and then slowly train them up so that they lose weight and their body gets more efficient, a weak heart will run that body better. So we hold the physical therapy or the occupational therapy if they have unstable rhythms, if they might have blocked arteries, if they're symptomatic and they can't participate. So for safety reasons. But we want to teach them what exercises they can do and why it's important to do those exercises. So that's an excellent question. It's all practical though. And so stiff ventricle or diastolic dysfunction is very much a function of aging. It happens when we age. It happens when things infiltrate the heart like amyloid or other proteins. It happens with LVH. Now, before we start, and we're going to start to compare and contrast systolic and diastolic dysfunction, I'm going to ask a question. I don't want an answer. I want you to think about this, and then we're going to ask this question at the end of the lecture again. Right now, if you were given a choice, I want you to pick, do you want to have the diagnosis in your own body of systolic heart failure, or do you want to have the diagnosis in your body of diastolic heart failure? So you have to have one of them. I want you to pick which one mentally. And by the end of the talk, I want to see if your opinion or your choice has changed. So when we deal with systolic dysfunction, there are a number of causes, and diastolic as well. And what's important here is if we can identify the cause and banish it early enough, remember remodeling again, if we can banish it early enough, we prevent the remodeling and we can cure them of heart failure. When we get them too far down that pathway, even once we get rid of the problem, we can't fix it anymore. So there are a number of infections from all different kinds of organisms, not just bacteria. Virus is the most common, but spirochetes and even parasites can make the heart weak. There are a number of bad behaviors that our patients engage in that lead to problems, and we can't help them with that. They have to admit to it, and then they have to stop it. There are some medications that can make the heart weak, some of the HIV medicines, some of our newer chemotherapy agents, and even one of our older chemotherapy agents do. There are disease processes that get into the muscle and disrupt its function. And then there are chronic inflammatory conditions, endocrine problems, and genetic problems. The newest type that we've kind of found is something called non-compaction. You can only diagnose this by an ultrasound. For some reason, something is going on in the heart. We think it's genetic, where the apex of the heart just gets these holes in it like Swiss cheese. It may be born that way, but we're finding the people when they show up with symptoms and the heart just becomes weak. There's no solution to this problem yet, but apical non-compaction is something you might see in echo. And this is the newest myopathy or the newest systolic dysfunction that is getting a little bit of attention. So if we think about what causes this based on frequency, idiopathic blows them all away. What that means is we're too dumb to know. That's what that word means. We can't figure it out. You got a weak heart, we don't know why. And this is unfortunate because if we can't figure out what made it weak, we have little chance of interrupting the remodeling process and making it better. Now, myocarditis, which is inflammation of the muscle, usually from a virus. COVID can do it. Thank God it's rare, but there are other viruses that make the heart weak. It's usually very difficult to treat these people and they usually die. Ischemia doesn't represent a big pile, only about 7%, but that's one that we can absolutely fix. And then there are a number of other conditions, and I won't belabor these. You guys can look at these in the future and, when you run into patients that have a problem, why are they having this problem, and then see if they meet anything on this list. So a word about diastolic dysfunction, or a couple words about diastolic dysfunction. All of you have seen echo reports. The echo reports mention diastolic dysfunction. Diastolic dysfunction is a description of how the ventricle fills. There's various definitions. In 2009, the American Society of Echo tried to redefine it. And their definition was very complicated, very much testing. The echo techs are, doing lots and lots and lots of measurements. There's a very complicated scheme to say somebody has diastolic dysfunction. And it turned out that more people were having diastolic dysfunction than living people on the planet. It was too broad a definition, and we were calling people with diastolic dysfunction that clearly didn't have it. So in 2016, they said, let's try to redefine this a little bit better. And when they redefined it, now less people have diastolic dysfunction than have diastolic heart failure. That's really not possible. So we don't have a good definition yet, but the best one we have talks about the pressures and the size of the atrium and the inflow across the valves. Now, diastolic heart failure is when diastolic dysfunction gets decompensated. So almost everybody over 70 has some degree of diastolic dysfunction in their heart, but not everybody has diastolic heart failure. So too often people see diastolic dysfunction in the echo report and they tell the patient you have congestive heart failure, but that's not true. These are separate entities. One is the signs and symptoms that go along when you're out of compensation. For instance, diabetics don't always have elevated glucose, but they have a potential to have elevated glucose. So what puts you in God's crosshairs when it comes to diastolic heart failure? If you're old, if you've got blood pressure, if you're obese or sedentary, if you have a bad lifestyle, if you have ischemia or diabetes or COPD or anemia, sounds like most of our patients. And we think that what happens here is any of those conditions create some sort of inflammatory insult. The body tries to remodel, the endothelium gets dysfunctional, it affects how the muscle of the heart works. What triggers somebody who doesn't have diastolic heart failure to go into diastolic heart failure? Here's a list for you of things that can do it. The most common ones we see are salt and fluid indiscretion by the patient at home, taking in too much liquid, the ventricle's stiff, it can't handle the volume that it used to, the blood pressure spikes for some reason, or they suddenly develop AFib and then the wheels fall off. Because when the heart goes fast, the heart doesn't have time to fill, and if it doesn't have time to fill and it's already stiff, liquid's not going to move forward. So these are the common reasons we see somebody show up with diastolic heart failure that never had it before. There are others though. what gives us any sort of prognostic value when someone has known systolic heart failure? Remember, we talked about the New York Heart class. The higher the class, the worse the prognosis. The wider the QRS, the worse the prognosis. The lower the EF, the worse the prognosis. If they have diastolic and systolic dysfunction, if both ventricles are involved, if they have hyponatremia, the higher the BNP, the worse the prognosis. Doesn't mean they're sicker, it just means they have a worse prognosis. So there are a number of things that worsen your ability to survive this disease, systolic and diastolic. If you have diastolic heart failure, RV dysfunction doubles your mortality. If you're fat with diastolic heart failure, if you have coronary disease, and the amount of tissue that's affected is very important. Now, with all of them, diabetes is always there. Diabetes makes everything worse. And coronary disease makes all things with the heart worse. When we have ventricular tachycardia, our symptoms, or I'm sorry, our prognosis gets worse. So for systolic and diastolic, both of these are in common. How do we treat systolic heart failure? First, we want to manage what's causing the problem. Again, back to remodeling, if we can prevent it, we don't have it. By modifying the lifestyle with medications, sometimes with devices, we'll get to each one of these in turn, transplant, rehab, and then our last step is always palliative care, unfortunately. What do we do with diastolic people? Well, we get fluid out, we control the blood pressure, and we treat what's going on behind the scenes, whether it's blood pressure or sleep apnea or arrhythmias or obesity. So again, similar to systolic, but we have a little bit more we can do in our systolic patients than our diastolic patients. What drugs that we have for systolic heart failure available? We're going to go through each class in a couple minutes and show why and what, but the drugs we have available for systolic heart failure definitely reduce symptoms. If they didn't, we wouldn't use them. They reduce hospitalizations, not all of them, but some of them keep the patient from coming back. So very desirable to use those. Many of them improve mortality, so they make the patient live longer. And again, some of them can reverse the weak muscle and make the heart function normally. But it's a progressive disease, it's going to catch up with us. But if we can reverse it, we gain a lot of ground. So it's important that we have the right drugs going when there's systolic heart failure. With diastolic heart failure, however, we don't have so much luck. Initially, Entresto was thought maybe to help, and then a subsequent study, and every time I mention a study, it's in green, that way you can pick them out easy. The Paragon heart failure study said, nah, Entresto may not. So the jury's out on Entresto, whether it's used for diastolic heart failure. It's a good blood pressure pill. It's expensive. Jardiance is our newest medicine. And in the Emperor Preserved study, they found that if you had diastolic heart failure and you put the patient on Jardiance, it did decrease hospitalizations and it did decrease death in these people. So Jardiance is new and upcoming, and you're going to start to see it in a lot of our heart failure patients. And we'll get to this again. Since it's an important point, I'll kind of reinforce it, but you don't have to be diabetic to get this. We're using sub-diabetic doses. So it's not like we only use this when you have diastolic heart failure and diabetes. So diuretics is a class for systolic heart failure. They are used to control symptoms. It's the first thing we give people when they come in the hospital. There are some small trials that suggest maybe they help with mortality, and then there's some bigger trials that suggest they don't. But there's safety issues. We're always making trade-offs in medicine. When we diurese aggressively, we shift potassium. We make the kidney angry. We can provoke arrhythmias. And this trials show that the higher the dose of diuretic you use, there's higher mortality, but there may be a pitfall there. It may be that sicker patients need higher doses, and those are the people that are going to die anyway. So is it the diuretic dose that's provoking the mortality, or is it just you're dealing with a worse class of patients when you get to that level and they're going to die anyway, and it's not the diuretic that did it? But diuretics have benefit for symptom relief. They don't keep people out of the hospital. They get them out when they're here. They don't have a lot of mortality data, and they don't change the course or the trajectory of progression of heart failure. Now, I said that, but there is a specific diuretic that does. Aldactone in both the RAILS and the Ephesus trial shows improved symptoms, improved mortality, but it does cause a lot of hyperkalemia, and we've got to watch some of our patients when they have bad kidney disease that we don't throw them into renal failure with aldactone. So aldactone is a specific class of diuretics that's very much helpful. And we're going to talk about how helpful each one of these drugs classes are on a future slide. Beta blockers. We all know beta blockers. We all use beta blockers in heart failure. Merit and Copernicus were the two trials that showed benefit. It really is one of our two first-line therapies in heart failure. And it's the one we can get away with more than any other specific therapy for systolic heart failure. It probably interrupts the adrenaline and epinephrine response of remodeling. It definitely improves mortality. It keeps people out of the hospital. It reduces blood pressure. And by slowing the heart with beta blockers, they have a longer time to fill. And if they can fill more, then they can push more forward on subsequent beats. So cardiac output improves. The EF may not improve, but the cardiac output improves. We have to watch, because if somebody is really bad in congestive heart failure and we throw a lot of beta blockers at them, we can actually cause them to decompensate. I don't see that a lot. I tend to be aggressive in the hospital, but on paper, and I'll show you what the guidelines say, we're really not supposed to adjust those doses, but every 2 weeks, but sometimes every 2 days in the hospital, I'm starting with a dose and adding, trying to get to maximum dose. Not all beta blockers are good for heart failure. Coreg, toprol, and bisoprolol are the ones that we have to choose. Other beta blockers do not have these benefits. Maybe they do, but they've not been studied. Some of them definitely don't. So these are the three that we tend to use in our patients. Why wouldn't we? If they have brittle asthma, if they're very bradycardic to begin with, if we don't have blood pressure to work with, those are reasons we wouldn't pick beta blockers. And here are what the guidelines say in terms of dosing for the various beta blockers, and what the maximum dose is, and then how often you should change the dose. ACE inhibitors. Well, the SOLVE and the SOLVE-2 trial show that ACE inhibitors definitely improve symptoms, mortality, and it doesn't matter. This is kind of class non-specific. You can really use any ACE inhibitor or ARB that you care to. It's not restricted to certain ones are good and certain ones are bad. So ACE inhibitors are second-line therapy, or one of our two best therapies. But again, if you think about how we're treating this heart failure, we're taking fluid away so they have less blood pressure. We're making the kidney angry, so the creatinine starts to climb. So sometimes we can't use ACE inhibitors because they're either too hypotensive or their creatinine's going up, and we're afraid of making the kidney worse. And then if the kidney craps out, volume builds up and we've made a bad situation worse. So sometimes we have to get our kidney colleagues involved to say, can we start this? They always like to, but I'm uncomfortable trying to manage creatinine as an outpatient and decide, am I making the kidney worse? I need the kidney doctor who's a lot more elegant with that than me to help as an outpatient. And then again, here are some of the dosing. Here's the maximum doses, and here's how often, according to the guidelines, you change them. I don't follow those guidelines, and I'm not ashamed to admit it. It seems to work when you try to push these doses up as an inpatient. If you try to have a visit every 2 weeks in the outpatient setting, patients don't come, we don't have room on the schedule to fit them, and then the dose never moves. So it seems to work in the hospital to try to push the dose up if you have blood pressure and renal function to burn. Hydralazine. It's a blood pressure agent. It actually, in the VHF trial, had some improvement in symptoms and mortality. We usually don't start with this first line. It seems like hydralazine is, its place in this is, let's get the normal things that we like in heart failure first, and then if we still have blood pressure, let's use it. And for some reasons we don't understand, in combination with nitrates, it's very much superior in African Americans compared to other races. So there is a racial difference across treatment for heart failure, and African Americans respond to this combination very well. It's not to say that they don't respond to ACE inhibitors and beta blockers, but if they're having trouble, this is a good place to go. They sell something called Bidil, which is hydralazine and nitrate in combination. It's a little expensive, or you can just give them 2 pills and tailor the dose of the nitrate and the hydralazine. And again, here are the combinations that we can use. Entresto. Entresto is one of our new exciting classes. It's an ARB with a second agent involved called neprilysin inhibitor. So when we use Entresto, we get some real benefit. So a question, and I want you guys to guess, somebody's on maximum therapy for heart failure. Beta blocker, they were on an ACE inhibitor. We're going to stop that because when we started Entresto, they get valsartan anyway. They're on aldactone, they're diuresed well. What kind of improvement in their cardiovascular death do we get if we add Entresto in place of that ACE inhibitor to someone already on maximal therapy? Do you want to hazard a guess?
30%.
20%
Ah,
improvement.
very good.
So this is a very valuable therapy to add. Now, there are some pitfalls or downsides to Entresto. It was studied in the Paradigm heart failure study. It does reduce death, whether it's just dying of death or dying of heart-related death. It does reduce the number of hospitalizations. It reduces symptoms. It was very expensive. The cost is becoming a lot more manageable. Also, it does increase BNP levels. So if somebody comes in on Entresto, their BNP level is going to be higher because Entresto pushes it up. It doesn't affect pro-BNP, but it does affect BNP. So we use pro-BNP. It's not going to be an issue for us here. It doesn't double them or anything like that, maybe like a 10 or a 20% bump. But it does cause a lot of orthostatic hypotension, and some of our patients don't have blood pressure to work with. And again, because it's got valsartan, sometimes it can mess with creatinine and kidney function. So Entresto is a very good medicine to add. So once we have beta blocker, which is cheap as dirt, once we have ACE inhibitor, which is cheap as dirt, if we want to try to make things better, we substitute that ACE or ARB with Entresto, and we're going to gain some real benefit. Patient's going to stay out of the hospital, they're going to feel better, and as long as their kidney function is being managed and it doesn't cost for them, it's going to be a better choice than an ACE or an ARB. Here's the dosing. It's a very odd dose. The numbers always add up to a multiple of 50. I don't know why they did it that way. I would have made 25, 25, but these numbers always add up to 50, 100, 150. I just don't understand it, but it helps you remember it when you see kind of these odd numbers. So systolic heart failure meds that can reduce symptoms include diuretics, ACE, ARB, and ARNI, that's Entresto, beta blockers, hydralazine with nitrate, digoxin, aldosterone antagonists like aldactone, and then a medicine called Corlinor. So these medicines all reduce symptoms, and then this category prolongs life. It makes our people live longer. Beta blockers, ACE inhibitors, hydralazine with nitrate, aldactone, and then Jardiance that we talked about a few minutes ago. And we're going to talk about that because it's our newest class and it's underutilized right now. But I've just sorted these groups of medicines into 2 lists so you can see, well, these help symptoms, these help life. So the SGL2 inhibitors, and there's a couple of them on the market, although Jardiance is the most popular right now. When they first came out, they tried them in diabetics that had heart failure, and they found that they were very helpful to the diabetics. And then Invokana, which is another one in this class, and the Canvas trial showed similar outcomes. So they said, hey, this is exciting. This group of medicines helps people that are diabetic with heart failure. And like any capitalist, they said, I wonder if we can help people that are not diabetic with heart failure. So they did 2 studies. One was called Emperor Reduced, people with low EF, and the other was Emperor Preserved, people with normal or high EF. And they looked at Jardiance at the 10 milligram dose because they're not diabetic. They don't want to give them doses that are going to shift the glucose. And these people were already on all the standard heart failure medicines that we've already talked about. And they said half of them are going to get placebo and half will get Jardiance. And they found that they reduced the risk of dying from heart failure by 5.3%. They kept people out of the hospital too. And it happened whether it was in the people with a bad EF or a good EF. And it didn't matter whether they were diabetic or not diabetic. So Jardiance is really a good drug to use in heart failure. And it's our newest, most exciting. And you're going to see a lot of people writing for that on the floors. Now, certainly, we don't know how it works for sure. We know it's not a diabetic issue. It may be a diuretic. It may improve endothelial function. This is how it might interfere with this remodeling process. It might improve metabolism at the molecular level in the heart cell and make it just a stronger beating cell. It might force more calcium into the mitochondria, which leads to a stronger contraction. We don't know, but these are speculated mechanisms. So of course, if there's good, there's always got to be bad. So what are the bads with Jardiance? Well, number one, it leads to infections in the perineal area. Number two, it causes postural hypotension. So does Entresto. So does some of our diuretics. Number three, it leads to polyuria. It's forcing more liquid out. So the patients don't like it because they got to run to the bathroom all the time. It can lead to diabetic ketoacidosis in diabetics. It can lead to acute kidney injury, like many of our other drugs in heart failure. It can cause more bone fractures. Don't know why. It is contraindicated if somebody has a lower GFR or renal function already. So there's good, there's bad, and of course, there's got to be ugly. And the cost is quite high. Now, the reps come to my office all of the time. They tell me, oh, it's only going to be $10 for your patient. It's only going to be $60 for your patient. And I don't disbelieve them. I think that they believe that, but I haven't met the patient that pays that yet for this medicine. So I don't know who that patient is. They may live in Washington. They may have left cocaine in the White House. I don't know, but there are some people that get it cheap, but everybody else pays a lot of money for this drug. So it's not really an effective drug yet for some of our patients that are indigent. I mean, Coreg and lisinopril, yeah, we can do that. Entresto is a stretch. Something like this, impossible right now. It's a good idea. I want to do it as much as I can. And then some of our financially challenged patients, they're not going to come back for office visits. So if they start to develop some of these other problems, especially renal failure, I'm not there to watch them. So I'm a little leery of Jardiance right now. I do believe it's going to have a big place in the future, though. All right. So if we use all of these therapies, if we combine every one of these and we take our standard new heart failure patient and say, take all of this stuff. First, they're going to be overwhelmed by the teaching and overwhelmed by the sheer number of pills they have to swallow. But how much do you think we help them?
40.
Yeah. So it's important to add all of these therapies if we can. It's big. It's a really big deal to help these people with this. So this slide gives us how much each one brings to the table. ACEs bring the most reduction in risk. Beta blockers bring the most reduction in risk. ACEs bring the second most reduction in risk. And then you can see the other ones going down the line in terms of medicines. And the Jardiance, it doesn't bring a whole lot, but remember when they were doing their studies, those people were already on maximal therapy. We might write a different set of numbers if we started with Jardiance and added some of these therapies after these trials. So we're going to switch from medical therapy to other things we can do. So why do people with heart failure die? Well, class 1 people don't die except car accidents and falls downstairs. Class 4 heart failure people die from heart failure itself. Class 2 and 3, they die from electrical disease, sudden cardiac death. So these people deserve to have a defibrillator. And you can tell it's a defibrillator because you can see the two shock coils. A pacemaker would not have these thickened areas on their leads. So if you look at the X-ray, you can immediately tell it's a defibrillator. First, it's a big battery pack and it's got the two shock coils. Defibrillators are put in by EP. They're generally indicated when someone has an EF of less than 30 or 35, depending on the criteria of the trial. And they're always started after all the optimal guideline therapy is started first. They're good for people with coronary disease and not coronary disease. So here's kind of a generic group of indications. There's always exceptions. And the fourth one stands alone. If you have inducible VT, we're not going to wait till you die to give you a defibrillator. If you go to the EP lab and we see that we can make VT happen in people, you're going to get a defibrillator irregardless of your EF or your New York Heart Association class. But you got to be alive for more than a year to get benefit from it. So we wouldn't give an 85-year-old or a 90-year-old a defibrillator. They may not live long enough to get any value out of it. So there's a second kind of defibrillator, and this is called a biventricular defibrillator. The difference between this picture and the last one is right here. There's a second lead in the ventricle. And the idea being that when we pace someone with a pacemaker, we're creating less than optimal contraction. If we put a second lead, instead of pacing like this, we pace from 2 points, we can improve the EF. So there are some people, optimal therapy, doing great, crappy EF, no symptoms. We put one of these in and we turn a crappy EF into a normal EF. So we expect that it would happen when the QRS is wide and they have left bundle branch block, but only about 50% of those people show benefit. So we still haven't figured out exactly who's going to benefit, but anybody that has a wide QRS, an EF of less than 35, and a left bundle pattern should get one of these after they've been on optimal medical therapy continuously for greater than 3 months, or if they had an MI and it's more than 40 days later and their EF is still depressed. We don't put them in for an MI right away. We let the heart heal up first. And so those are just the criteria. Again, some people have been adjusting the time frame for the QRS to see if we can refine this further, but we haven't gotten anything better. But it does reduce mortality, so it saves your life. It does reduce hospitalizations and it improves functional status. A regular ICD reduces mortality, but it doesn't do those other things. And then advanced therapies, which we don't really offer here, but if somebody's in really bad heart failure, we start them on dopamine or dobutamine or medicines to support their pressure, but that has to be a bridge to something. If there's a blocked artery, you have to fix the artery. In other situations like Emory, St. Joe's, Piedmont, they'll put continuous IV inotropic support on people. They walk around with a backpack pump that has dopamine or dobutamine or some of these other agents, milrinone, and they live on that medicine constantly and continuously because they're on a list for transplant or they're on a list for an LVAD. And this is, there's two kinds, but this is an LVAD, kind of an artificial heart. They don't take the old one out. They just add this in tandem. And this heart beats and moves blood for the patient so that it assists the ventricle. They have RVADs and LVADs, and some people that are really sick get both, a right and left ventricular assist device. These are very complicated. They're prone to clot. They're prone to infection. They're prone to all kinds of failure. These people are sick, and they should be seen at specialty centers. So when do we transplant? When we have an emotionally motivated, well-informed patient, but they can't have an infection, they can't have cancer, they have to have a good creatinine, or I'm sorry, a bad creatinine clearance, they can't have systemic diseases or drug or alcohol abuse because we're turning their immune system off. They won't do well if they have these conditions. And then there are drugs that we definitely avoid in anybody with congestive heart failure. The most common one on this list that you might see are things like ibuprofen. Ibuprofen makes the kidney about 10% less efficient, and it makes you retain fluid, and it can put people into congestive heart failure. But there are several others that we try to avoid. So I asked you earlier, do you want systolic or diastolic heart failure? Has anybody changed their mind? So systolic and diastolic heart failure are equally common in the population, but we have much better treatment for systolic than diastolic. Congestive heart failure is kind of tricky to diagnose. It gets worse over time. And we can do a lot more for the systolic than the diastolic people. The diastolic people got to do a lot of the lifting on their own. Do they need to scan that?
So thank you very much for. So the QR code here up on the screen is for the evaluation to be able to get. Hold on, I'll put it back. Yeah, there we go. And that's for the evaluation to get your CE credit. I'm gonna drop in the link into the chat box. So those of you online can also click on the survey monkey link there, copy and paste that into your copy and paste that into your browser to do the evaluation.
It's slideshow, but I click on the slide. And bring it up in there.
Yeah. Okay. So I know Dr. Siegfried will hang around for a few minutes for questions. I'm volunteering for that. But thank you very much. Again, very good conversation. I stuck with systolic at the beginning. I'm sticking with systolic heart failure now, but really I
It's a
don't.
better one to have.
I don't want to have it. I don't want any of it. So thank you again. Thank you all for being here. This is a great turnout today. And I'll go ahead and put a plug in for August. So August 8th at 7:30. Jennifer Davenport's assistant CNS for acute care. And she's going to be talking about delirium prevention and management, and what we're looking at doing as a system here together. So she'll be offering a CE next month for that. And then I'm hoping for September, I'm lining up a gentleman named Chad from Gwinnett County EMS to do some talks on compassion fatigue and also emergency preparedness and some stuff from the community standpoint as well. So a couple of different, lots of variety in our discussions. So but Dr. Siegfried, thank you again. It was a pleasure to have you here. So real quick,
Any questions in the room?
I do have a comment here. You're amazing, Dr. Siegfried. Thank you.
I think I pay her salary.
So great talk, Dr. Siegfried. Thank you very much.
Thank you all for coming.
Thank you. Real quick, we have a couple of items to raffle off. So do you have your random number generator?
I've got a random number generator for 20.
And we have a couple of lamps, a thermos, and a utility wagon real quick. So they'll hang out. We have numbers 1 through 20. Yep.
Well,
Number 12. I apologize.
on.
Would you like? Come choose your product.
It's Stanley thermos. We have some
Touch
top lamps.
lamps.
Monster. Tiffany got these last time. She's talking about.
Touch lamps, wagon. Okay, next number.
Graduated today.
For last week.
20.
Number 20. Laura. Monty.
I think I want the utility box. It's all yours, that big box. This big box. Heavy, that box. We got a plant, these are.
That's a lamp and a lantern.
Yeah, it's all lamp. It does the cord thing that goes together. All goes together.
Amen.
Okay. And
Jennifer Legan.
I didn't get all my prizes. We had such good turnout though. That's not beautiful. Yes.
Okay.
Thank you.
Grandma? Mary, here we go. 19. Whichever one you'd like, whichever of those prizes in there. Diana. No. So these are both touch lamps. They don't have that. They're both touch lamps. Ashley Hall. Wow. Thanks today. Hey, well. My dog, like, I'm staying here at night, I'm like watching, slap at it.
Oh,